Good afternoon. This is Rebecca Roper of the Agency for Healthcare Research and Quality, and I'm joined today by a wonderful team from Booz Allen, Christine Martin-Anderson, Anjanette Fleming, and Christina Marsh. And we are going to provide to you a very high-level overview of our just-released report entitled Health IT-Enabled Quality Measurement, Perspectives, Practical Pathways, and Practical Guidance. And because of the large number of folks who are online today with the webinar, we're going to ask that you consider posing questions to us that we will collectively respond to in the future. We're not going to have the luxury of having an interactive question and answer session with you, but we will make every effort to respond to your questions and post them on the website. To that end, within a couple of weeks, we will have both the PowerPoint that you'll be seeing today and the transcript from today's presentation available for your review and for others who choose to come join us and review this information retrospectively. I need to acknowledge that this particular project was the brainchild of Dr. John White, who is the Director of the Portfolio for Health IT at AHRQ. About 4 years ago, he thought it would be a nice idea to get a snapshot of what was happening. So many things are happening with CMS, ONC, with payers, with actual healthcare institutions, and and vendors, and trying to leverage the opportunity of what health IT can provide in terms of quality measurement, both in retooling of extant quality measures and developing new quality measures that can truly inform a quality improvement cycle. And he tasked us to go forward and see what we could find by engaging a multidisciplinary stakeholder group through an iterative process. And we'll just kind of give you a high-level summary. So as you know, improving quality is really a national priority across all stakeholders. Quality measurement can be an instrumental means by which we both assess where we are on an individual level, be it either the individual of the healthcare provider as a clinician, an institution. It can also provide population-based quality measures. There's many different ways in which quality measures can be focused and targeted. In order to understand how the advancements can be made, we need to understand where we are. So last summer, the Booz Allen team went out and embraced the literature and embraced our stakeholders to find out about projects that were ongoing, challenges, and gaps. They produced the snapshots report that was well received last summer. We used that as a framework to frame a non-regulatory request for information that was issued last year. And we were able to solicit over 60 folks participated in the public response to the RFI, which had 15 questions. And then we used those responses to help inform various focus groups that were conducted over 2013 to provide contextually relevant information. We are providing you high-level summaries and more detailed feedback that we received through these different activities in this over 100-page report. Our goal today is to provide you some highlights of that report and to help whet your appetite to delve down further into the report. And depending on your level of interest, you can either look at the more detailed information in the appendices, or you can engage in more high-level consideration. As I said, we did pursue a diverse group of stakeholders. You can see that we engage with providers, payers, measure developers, consumers. Now, one thing to know is we had folks who were interested in, from the patient perspective of consuming quality measures, but we did not have patients explicitly engaged from that perspective. So our ability to inform what patients might be interested or needed is garnered through surrogate information. It was not intended to include patients explicitly, but that is a limitation of what we're going to present to you. We had a very robust response with respect to vendors, predominantly from electronic healthcare record vendors, vendors, and various government entities. We do not identify who said what in terms of the actual who provided what particular comment. However, the nature of the stakeholder is identified in some of the material in the background, which helps inform what's driving someone's perspective. The report just went out. It's available on AHRQ's website. You were sent the link earlier today, which is wonderful. As I said, it's 110 pages, so we're hoping that we'll be able to entice your review of it. In the report itself, I'd like to highlight a few things. We have traditional elements. That Chapter 3, which is about 20-some pages, is a distillation of the perspectives with respect to how people approach quality measurement, how people are approaching it differently, and how that may be informing both their priorities of what to do and their ability to be risk takers and for the context. And we're going to explore those perspectives a little later on. Christine Martin-Anderson is going to lead that discussion. The pathway, section 3.2, it really delineates various opportunities where either we can replicate extant activities more broadly or perhaps address infrastructure gaps that, if fully addressed, that we collectively would be able to proceed and realize more of what can happen with health IT-enabled quality measurement. So that's more of a list as stratified by 5 categories of what folks thought really needed to be accomplished. This report is not written as a directive or strategic plan of what AHRQ will explicitly be doing. It really is provided to understand what we as a collective community or those among us may choose to pursue, and you may already be pursuing, but it's an opportunity to share what folks thought needed to be addressed more thoroughly. In practical guidance, section 3.3, there is a discussion in the reflection section in chapter 3, but really a lovely resource at the end of the document is Appendix C, which is a partial catalog of current activities. So we have over 150 of current activities that were actually identified either through the responses to the RFI or through all the focus group engagements. Hey, someone's doing something, it's helpful. It could be, this is the data integration. It has different components. It doesn't have to be all things to all people. And we have gone through, and the Booz Allen team has thoughtfully coded Appendix C to identify functional, topical, and special interest quality measurement characteristics. So we're not going to be delving down into that particular resource right now, but that's something when you step back, perhaps not on Friday the 13th, but later on next week, and kind of reflect and look at perhaps someone else is pursuing an activity that you two are trying to replicate. Let's see what they're doing, and they are hyperlinks to different information on the web. Okay, so stepping back a little bit, when we engaged in this particular project, we were very clear that we were not engaging in a regulatory effort driven, though informed by meaningful use. We were not seeking to step into the regulatory activities of CMS and ONC with respect to the stage 3 of meaningful use. And that type of decision making is still the province of our dear friends at CMS and ONC, and we are stepping back to provide more incremental ideas of how collectively advancements can be made, which of course in part may inform the direction and the requirements of meaningful use, but we will not be commenting explicitly on meaningful use activities. With that, with respect to comments, so we aren't in a position to be able to answer question and answers during this webinar, but if you could bear with us, since you are a group of folks who are willing to take chances and are on the cutting edge for health information technology, we would like you to bear with us. We're going to try something new. At 2 intervals, at about a third of the way through the presentation and then again another third of the way through the second third of the way, we are going to pause, give comments with respect to two topics that we could explore more fully in subsequent presentations. Particularly, the first question that we're going to pose to you is the types of information that you would like us to discuss with respect to what makes quality measurement actionable. We'll ask you to take about up to 4 minutes to provide us feedback on that. That feedback will be used for consideration of subsequent presentations. We'll have that same exercise to collect feedback polling a little later on with respect to patient engagement as well. At the end of the presentation, we ask that you take up to about 10 minutes or so and really provide a substantive comment on the types of information and categories that you would like to see us explore further if we had an opportunity to present this information in more detail at a later date. And so with that, I will turn it over to Christine Martin-Anderson.
Thank you, Rebecca. So now we want to get into some of the meat of the report itself. Through the RFI and the research and the focus groups, the highlight good news is that there continues to be nearly universal commitment to working through the challenges that are related to implementing health IT-enabled quality measurement. There was recognition that there's been progress. There was certainly a chorus of calls for improvement going forward, but an incredible amount of support for continuing the journey. We want to highlight a couple of areas of consensus that stood out most strongly. One was that measurement should be patient-centered, and this is a key aim of the National Quality Strategy, and we did hear this in two different flavors. One was that we need to have measures that matter to patients, and that there was some work we needed to do there, but there was definite commitment to getting there. And also to consumers and patients as valuable contributors of data that should be considered for future metrics of the quality of the healthcare delivery system. The second was that measurement should be supported by end users, education, and collaboration. What we mean by that is there are a lot of many parties and stakeholders who are engaged in quality measurement, particularly in quality measurement that is enabled by health IT. That include, as Rebecca mentioned, payers and vendors and patients and consumer groups and measure developers, those being measured, those doing the measuring, those facilitating the measurement. And there was a continued call for all parties to have a broader context of the system of quality measurement across stakeholders, so a strong support for continued collaboration, and there are many examples of collaboration that you'll find in the appendix and in the report. That measures should be aligned to national priorities. This is both expressed in terms of reducing burden, but also expressed in terms of focusing attention on the areas that we could get improved quality by focusing the attention of those who are trying to improve the quality. That measurement should be actionable and build to work within a system of quality improvement. Again, the familiar call of no measurement for measurement's sake, that there should be a connection and a more explicit connection between measurement and improvement, and that IT enables both the measurement, but also it can have a more direct connection to decision support and other point-of-care tools. And lastly, that technology should be used to support measurement. We should use technology to increase automation, to also increase the capabilities of measurement as well as the capabilities of technology, and also a strong support for the coevolution of technology, care delivery, quality measurement, and improvement, that it's a worthwhile cause to continue to try to evolve each of these dimensions together. Stakeholders also articulated that quality measurement that's enabled by health IT should lead to a more comprehensive system of measurement improvement, something we're calling e-improvement. And picking up on where I left for the last slide, coevolution really is the key here. Our end goal is not simply to automate the measurement process, and when I say our, I mean I'm reflecting the stakeholders' viewpoints. It's to enable a better, higher quality healthcare system that effectively engages the professionals, the vendors, the patients, the families, et cetera, in the improvement process. So a fundamental need for an applied research agenda sort of to move that e-improvement forward. So that was also wonderful to hear such a consensus. Now, everyone didn't agree on everything. So as we talk about the perspectives, and we listened to so many stakeholders express their views, we began to realize that the problem was come at in many different ways, depending on how one felt about fundamentally how much measurement should be used as a change agent. And what we found is that RFI respondents and focus group participants and researchers, they, as an example, almost universally support measurement in new areas where we'd like to push the delivery system beyond the status quo. And examples of that would be care coordination, patient-reported outcomes, longitudinal measures, more expansive looks at ultimate outcomes of care. But each of those changes, each of those new areas of measurement, as an example, really would push the current capabilities of health IT or push the current delivery system and induce workflow changes or IT changes. And so there were multiple different perspectives around how the prioritization should happen and where energy should be focused in order to reach the goals of health IT-enabled quality measurement. And so we articulate 4 of them here and further on the next slide. And we tried through the report to call out where a difference in perspective might result in a difference in viewpoint as to where energy should apply in the short term versus the long term. So I thought that was very interesting. And we also would note that there isn't a right or wrong in this. In fact, the same individuals might have an alternate perspective when thinking about a new topic. So, for instance, it may be considered, worthwhile to pursue efforts around trying to get, for one stakeholder to say it's worthwhile to pursue efforts around longitudinal measurement because they really want to encourage greater health information exchange and data sharing, but they might not feel exactly the same way when you ask them about, say, for instance, allowing patients to enter data that's going to enter into the medical record and be used to assess clinicians on whether or not they're able to improve functional status, as an example. And that's a notional example. And so you find that the perspective does change, and we also found it useful as we move forward for collaboration that it might be helpful to kind of call out where those perspectives are different and what might be driving a different point of view. Here we want to just dive into a little bit around what the 4 perspectives are in a little bit more detail. The first is we're calling, and we created these names, quality measurement, accelerating, systemic QI is the highest priority. And we characterize this area for stakeholders that would, for example, say that improvement is the main goal. Let's not worry so much about how much it changes the status quo. We need acceleration. Let's put those quality measures out there. If they're the right measure and it's the right thing to do, let's put it out there. And this is the area of when the perspective is most supportive of using measurement to induce change and innovation. The second perspective was one where we said, well, maybe not so fast. We're in the middle of implementing a lot of electronic health records and other technologies. We have a lot of stress on those systems. There's already a lot of new information that's available generally if you install a specific electronic health record. Let's really focus our efforts on measurement to those measures that can most effectively be created, maximizing the use of the IT we just spent so much time and effort implementing. So if it's not currently supported in the existing technology, perhaps it should wait. A third perspective is sometimes characterized as saying, let's make sure that the care delivery comes is always put first, and if the current delivery system cannot handle the workflow change that's going to be required to support doing well on that measure, perhaps we should not allow measurement to be disruptive to a broad degree to the delivery system. And again, the same stakeholder can take different viewpoints if you're talking about a different topic, but it would say over time and across specialties we'll incorporate QM and QI into clinical training, and then over time it might be more appropriate to introduce measures that would reflect, say, a greater embracing of team-based care, for example. A fourth perspective was, really kind of let's try to get a convening body together and just explicitly make trade-offs across these various perspectives and have sort of the master list of what we think is acceptable. And somebody or some entity should be aligning and harmonizing across these various needs in the community and suggesting where the prioritization should occur, and then all measuring entities would ideally follow that lead. So that's another perspective that we heard.
But Christine, in addition to the folks having different perspectives that they may choose on different topics, in reality, we would find most activities for health IT-enabled quality measurement would really be some blend.
Absolutely, right. So it's not, Rebecca's right, it's not just that you could take one perspective or another, but there can be ways to think about balancing across perspectives, or even a blended perspective that was unique to that individual's belief and how the quality improvement should be sought. I think that's part of it, where the priorities were. So we didn't articulate these to say that let's pick one. We really articulated them to say it's helpful to know and articulate where you're coming from when you're participating in a multi-stakeholder dialogue around prioritization, et cetera.
And it was really telling when we looked at in particular the RFI respondents' content, regardless of the particular focus or the request for information questions, we began to see this pattern of possible perspectives. And then that actually was reinforced in the individual focus groups, where it became stronger and became apparent. And this is why we offer the 4 perspectives for your consideration, to facilitate dialogue, to see where you are in a particular project, and maybe the consideration of 4 perspectives will fly and will help promote discussions, or you may modify them or not find them particularly helpful. Of course, as I said at the beginning, we really didn't reflect, by virtue of our focus, the patient perspective. And as patients become more engaged, they will, of course, have impact on these 4 perspectives as we've presented them, and provide their own perspective as well. So now we're going to take a moment and we're going to try, and you're going to evaluate this, whether this works or not. So now we have, you'll see up in your corner, an integrated question where we'd like you to just take a few moments and get feedback to us with respect to what type of issues around making quality measurement actionable would you have liked us to focus on in this presentation, and this will help inform subsequent presentations. So we're just going to give you a few minutes, kind of directed multitasking, for you to provide us some feedback. We won't be able, this will not be shown live during the webinar. We will look at this collectively after the webinar.
Thank you for taking the opportunity, or giving us the opportunity to test the polling. We're going to move forward now, and I'm going to hand the baton over to Christina Marsh, who's going to take us through the next couple of slides. Christina?
Thank you, Christine. As we began reviewing the RFI responses and held the focus groups, we found that many of the comments could be categorized into 5 key topics. The measure development lifecycle, which is inclusive of measure development, implementation, and testing. Data elements and data capture, as well as the tools to process unstructured data. Data access, sharing, aggregation, and integration. Patient engagement. And finally, collaboration and education. Next slide, please. The eMeasure development lifecycle and some of its associated challenges and concerns were frequently mentioned by the RFI respondents and the focus group participants. Beginning with measure ideation, there is an increasing need for measure users to determine what will be measured. The stakeholders also suggested that better alignment with other quality and public reporting and certification programs would be incredibly beneficial. Moving to measure specification, improved e-specification is very much needed, and stakeholders stress the desire to include a wide variety of data elements for the purposes of measurement. The stakeholders also suggested that measure testing requires standard approaches and faster cycle times. Further research is needed to test the reliability of chart abstraction versus electronic health record generated quality measures. Variability in measure implementation needs to be reduced and more automation is needed. And finally, stakeholders indicated that measures should be reevaluated regularly to determine if they are meeting their intended purposes. Now, the RFI respondents and the focus group participants repeatedly emphasized the importance of collaboration and that collaboration should be increased throughout the entire life cycle. We'll be discussing collaboration more fully later in the presentation, but for now, one recent example of how collaboration is already facilitating improvements across the eMeasure development lifecycle is the Kaizen event, which was hosted by ONC and CMS in January of 2013. The event focused on opportunities to make the eMeasure development process more efficient and effective. Cross-contractor, cross-agency, and cross-stakeholder work groups really examined each stage of the life cycle, and they were able to identify specific actionable steps to improve the eMeasure development process. These work groups are continuing the work that was begun in January and are now joined by NQF as a facilitator. These piloting efforts are addressing many of the same issues that were brought up by the RFI respondents and the focus group participants. Now, reflecting back to the perspectives on health IT-enabled quality measurement that Christine just described, you can see how the perspectives of various stakeholders might impact approaches and priorities throughout the measure implementation lifecycle. So, for example, stakeholders generally agreed about the importance of measures across care settings. However, stakeholders that align more closely to constraining new measures to current health IT or delivery system capabilities might prioritize development of measures that are easier to implement over measures that require new systems development or further action on the part of providers or their staff beyond the traditional workflow. Alternatively, stakeholders that are more aligned with accelerating systemic quality improvement might give higher priority to certain cross-care setting measures if those stakeholders conclude that these measures are so important and critical to improving care that the time it might take to implement such measures or the implementation burden is considered acceptable. So with that, I'm going to turn this over to Anjanette Fleming, who's going to discuss some of the next topics.
Thank you, Christina. The second topic around which RFI respondents and focus group participants seemed to coalesce was data elements and data capture, including tools to process unstructured data. They stated that producing highly reliable and valid quality measures, especially if downstream they might be considered for high-stakes uses such as reimbursement, require consistent and high-quality data. To accomplish this, they recommended that there needs to be standardization in measure specifications, data elements, and the processes for capturing and storing data elements. Beginning with specifications, stakeholders stress that specifications must be clear. They should also anticipate high-quality data, and this data must be made available. As far as data elements, they stated that they must be clearly specified and accessible. The supply chain for quality measured data is very complex. It hinges on the technologies such as user interfaces, data stores, data capture technologies, and also processes, the clinical workflow and various data validation processes. So there are a lot of things in that process that can instigate change. Changes in care delivery, variability across EHR vendors and applications, increased depth and complexity of clinical information can all impact data reliability issues. Accordingly, RFI respondents and focus group participants cited data quality as a major barrier to e-measurement. They talked to us about things such as inconsistencies in the scope of data elements captured in different systems, frustration with increased requirements for data entry, problems with interfaces, difficulty in retrieving data, and imprecise measure specifications. All of these they mentioned as challenges. This was also brought up in the context of data reuse. We did talk to participants about how sometimes you might choose to collect data for one purpose, but then use it for another. But they did mention that although that seems like an efficient use, it becomes all the more important to ensure data quality, because if there are inconsistencies or erroneous entries, all of those are going to be a problem downstream. Standardization, they also said, of data capture was discussed as both a data entry issue and a workflow issue. Stakeholders are interested in tools to ease data entry. So they talked to us about a lot of different things. I'll touch on a few in a minute, but different opportunities that will ease the burden of data entry at the point of care. Another thing they talked to us about with regards to standardization and consistency is the measurement of similar concepts. There was one example that was given to us where you might have a measure that is tobacco use and another one that is cigarette use. So measure results might be similar but not always comparable across programs. There was recognition then that common measure specifications may not be sufficient for comparability and would need to be looked at. Alignment down to the level of data capture and data storage might actually be required. One thing that, as Christina mentioned, testing, both data capture and data storage need to be tested for comparability at the measure implementation level where too few tools exist. So there were a lot of challenges there in trying to figure out that comparability and how data is collected and that it's really doing as is hoped. So one of the specific topics that was discussed around ways to ease data entry was natural language processing. They also felt that natural language processing would be most effective for things such as to validate measures, to identify patient exclusions and inclusions, and to assess the reliability of free text. For all of these, though, it was noted that there needs to be additional testing. There was some concern around relying on the current natural language processing technologies for measurement purposes. Focus group participants suggested that an evidence-based report should further examine the potential use of natural language processing for quality measurement. Other potential tools that focus group participants mentioned were things such as voice translation technology and qualitative data analysis software. But again, even with these tools, they recommended that additional testing would be needed to make sure that tools designed to handle unstructured data are working properly for the purposes of quality measurement. With regards to the perspectives that Christine talked about, you could hear some variations when we talked to focus group participants and when we saw RFI responses, depending on their perspective. Some measures may only require data available in EHRs as collected as part of workflow. But then there are other measures that were stated needed to be able to get into that data across different systems. And so the measures that could be prioritized would really depend on the access to data elements and how quickly new data elements could be made available. A few ideas that we were given, I'm sorry, go to the next slide, please. Actually, Rebecca, I'm going to let you talk about this real quick with regards to natural language.
Real quickly, before we leave data elements and data capture, I also wanted to reflect, this is Christine, that there was interest in data from systems other than EHRs, and we heard interest in how to better use registries, the lab and radiology systems, etc. Okay, Rebecca?
So in the body body of the report, you can see a call-out box. As far as natural language processing, that would be mentioned on occasion in response to various RFI questions. Some folks would say, hey, I think this is a great idea in order to get contextually important information that's only perhaps in the notes. Under what circumstances and what type of quality measures could be customized that could leverage natural language processing. We didn't have a definitive pattern, but it was a recurrent, possibly this could be a solution for some information that's not directly extractable in this structured data. So as Anjanette said, the recommendation was made through the process of getting feedback that AHRQ considered have a systematic review of when natural language processing could be used to inform or has been used to inform health IT-enabled quality measurement. So as folks are inclined, this is not a commitment that AHRQ would do this particular type of research, but as folks who are interested in this area, you have an opportunity to work amongst yourselves to pose the types of questions that you would like posed in a systematic review, and AHRQ would welcome those questions and for consideration of possible conducting a systematic review as customized or informed by your feedback. And we would appreciate, given the recurring comments with respect to natural language processing, for those of you who that's an area of passion, that you consider working together and making a submission for possible consideration as a report that we would have generated. I just put in a plug, but back to Anjanette.
Okay. Now, dovetailing off of data elements and data capture, another topic that kind of goes together with that is data access, sharing, aggregation, and integration. Like Christine was saying, that stakeholders really said, hey, you know, the data that's in the EHR is great, but we really need a lot more. And so information exchange is really, really important, especially for particular types of measures. So stakeholders felt that it's critical for many of the quality measures that RFI respondents and focus group participants have indicated are needed, such as longitudinal measures, episodic measures, and patient-reported outcome measures, making it critical that all barriers around data access, sharing, aggregation, and integration are addressed. RFI respondents and focus group participants indicated they're interested in the information available in EHRs as well as available from other sources, such as some we already mentioned, claim system, registries, pharmacies, laboratory, radiology, and other such systems. And we did hear specifically from payers that they would be welcome to all data made available to them and could use them for a variety of data sources, data uses. Pertaining to data access, lack of adoption came up as a remaining issue, especially in specific care settings, such as home health care and long-term care. These settings are still struggling more than others in adoption, and although some of them do have electronic systems, many of those systems are not yet interoperable with many EHRs, making it difficult to share across those care settings. Concerns around data quality were often raised pertaining to the ability to effectively share data. One focus group participant specifically said, who is the source of truth if the data is in conflict when it is shared? Others further expressed that they might become legally responsible for data now available to them, although they might have limited or no means to assure or amend data accuracy. So that's something that has to continue to be explored. Most challenging issues, however, seem to be around policy issues, not technology issues. We had another person that said the most challenging issues anticipated in terms of data aggregation and integration are around policy, privacy, governance, and data ownership. The technology is pretty straightforward. So specific policy issues were then discussed by stakeholders, and they talked about those issues, ownership, governance, and the need to address sensitive data, the need for model policies around data sharing, the need for shared accountability, and some type of a patient identifier and how that might work. There were a number of possibilities that were discussed or ideas that were talked about. Examples included standard data definitions and data elements to ease some of the technological challenges of data aggregation, new tools for data aggregation and integration, methods or systems for shared accountability, and robustly tested model policies and constructs. And the last thing that was talked about in a greater amount of detail was patient identifiers. Many of the RFI and focus group participants agreed that patient identifiers are critical for linking data across multiple sources. One participant noted that health information exchanges or other data sharing efforts that have been most successful have used some type of common identifier. They gave us some different examples of some different type of identifiers that are being tested, and that needs to continue to be explored. Focus group participants, however, indicated that although they believed it would be unlikely that a national patient identifier would be implemented in the near future, it was very important to have some type of a locally based or geographically based identifier to share data in a given locality across non-affiliated healthcare providers. Of course, this becomes more critical in areas where there are a lot of different health systems on different EHRs, and probably would be less critical in areas where there's one health system on one enterprise system. Over the course of our conversations and research, a new alliance addressing many of the issues around data access and sharing across health systems and vendors was brought to our attention. One of the challenges that was repeatedly brought up is that simply a lot of times things between EHR vendors are proprietary, and for good reason, but there needs to be a way to communicate. So we heard about this new alliance called the Commonwealth Health Alliance, and they are made up of different vendors. Some of the initial participants are Cerner, McKesson, Allscripts, Athena Health, Greenway, and Relay Health. And they represent about 41% of the hospital EHR market and 23% of the ambulatory care EHR market. In a press release that they put out, they said that their primary goal will be to define, promote, and certify a national infrastructure with common platforms and policies. So that's just one example of how vendors are going about trying to ease this challenge. The ability to exchange clinical information between healthcare entities does create new opportunities for patient safety, care coordination, quality measurement, and improvement. Health information sharing organizations throughout the U.S. are starting to come about to implement such sharing. In fact, when we looked at some research, we saw that just about every state, if not every state, had at least one health information exchange, with several states having many across their state. In fact, states such as Georgia, New York, Montana, California, Nebraska, and Indiana are considered innovators. And you'll see here on the slide we have some information specifically about the Indiana Health Information Exchange. They currently connect more than 90 hospitals and 110 clinics and surgery centers across 17 states. And you'll just see here, for the sake of time, you'll just see here some other statistics about health information exchange in Indiana and some of the things that they're doing. So I'm going to pass it back now to Christine to talk about patient engagement.
From a personal view, I think the dialogue around patient engagement was some of the most innovative, as in net new ideas coming forward around ways to think about engaging patients. And I think that's true across healthcare right now, not just unique to measurement. And so patient engagement, which is inclusive of the engagement of families and caregivers in the care of patients, was frequently suggested as a major way to improve health outcomes. And the quote that you see on top of that slide is actually from Dr. Farzad Montashari, our current National Coordinator for Health IT, who said that patient engagement is the blockbuster drug of the century. And essentially, ensuring that each person and family is engaged as partners in their care is one of the National Quality Strategy priorities and among the meaningful use requirements. So stakeholders in the focus groups and in the RFI frequently discuss the importance of patient engagement and how it can relate to quality measurement that's enabled by Health IT. Our focus group participants suggested that patient engagement and quality measurement can lead to shared decision-making and can enhance successful provider-patient relationships. Despite its value, participants noted that the intersection of patient engagement and quality measurement can be challenging, and that patients, families, and caregivers are not often effectively engaged in conversations around quality measurement. Much of the dialogue focused on the measures themselves, that the measures must matter to patients, with the reflection that the current measures that are used for quality, to report on quality, are really designed to be valuable to professionals and institutions who are engaged in providing care. And they are not necessarily created with the patient in mind. And also that the patients, the technologies with which they're presented are not always, are not frequently presented in a way that patients can consume them. So if you think about the times that our stakeholders suggested patients most want access to quality measurement, when they're selecting a provider, when they're selecting a treatment, or when they're measuring progress against their clinical and personal goals, the stakeholders articulated that the measures that we have today really are not the measures that suggested they're not the measures that the patients and consumers actually most desire to see. In particular, the theme of personalization came up, that the personal goals, not just the goals for the treatment, but what the patient hopes to achieve as a result of seeking treatment. The measures must be actionable for decision making. And I think that gets at presentation and availability at the right time and place, well organized and easy to understand. There were comparisons made between healthcare and other industries. For example, the open table applications in dining or TripAdvisor for travel, saying that there's a lot to be learned about how consumers and patients would want to view information about the availability of providers, the quality of providers, and the overall rating of those providers. That tools for obtaining measure information or for contributing to measurement should be common and easy to use. And this really came into play both in how a consumer or a patient or a family member could contribute information that would be valuable in assessing quality, as well as accessing that information. It was a very robust discussion that unfortunately we couldn't explore in too much detail because, as Rebecca said at the very beginning of this presentation, we did not have a stakeholder engagement process that would have been fitting to getting some of reactions directly from patients themselves. We had consumer advocates engaged in focus groups, but we were unable to speak directly with patients and families. And stakeholders recommended that further conversations directly with consumers should occur, and we should focus on how and why those patients might use quality information, as well as what information patients and consumers are most interested in and how they'd like to see it presented. This is an area definitively for future research. And they both around what the needs are to fit each of those decision points, those moments of truth that patients and consumers face, but also the best mechanisms for presenting the information and how to evaluate whether or not those the information that we're providing is assisting in the decision-making process. One focus group participant noted clearly that tools for patient engagement and quality measurement cannot be designed for patients. They had to be designed with patients. And that certainly is not a test that, could easily be met today. There is progress toward allowing the patient to take more direct action, and the example that we give on the Blue Button Initiative is not explicitly a measurement activity, but really a data exchange activity that allows the patient to be directly engaged in the process of moving their information and allowing their information to be shared from one party to another. Several other organizations are conducting additional research and pilots in this area, and you can find those in the appendix of the report and in the body of the report. And also additional recommendations around collaboration and education can be found in the table of suggested steps toward enhanced health IT-enabled quality measurement in the report itself. Rebecca?
So just to follow up, in the highlights that have been given, and when certain examples are given, they are just examples. We know that there's a large group of hardworking folks out there, and if we do not mention our feature year project in the compendium or as examples here, it is not to slight the activities thereof, but we are just embroidering with examples. So we do not have the tapestry of all that is happening with Health IT-enabled quality measurement. So just bear with us with respect to that. Another point of information, earlier folks were talking about data integration and use, health information exchange being very important. Clinical decision support was another dimension that would be spoken about. In the appendix, there's a table that looks at which of the responses to the RFI may have mentioned either Health Information Exchange or CDS, which is rather interesting. Of course, the particular question that was geared towards clinical decision support, there was 100% concordance. But in actuality, most of the responses we received to the RFI were oriented to information being available at one particular healthcare setting or healthcare system through an EHR. Some of the other respondents or the focus group participants were more comfortable or familiar or explored the effect of health information exchange or in various formats and clinical decision support. So I just bring that to your attention. So now, before we get to collaboration and education, we have an opportunity to have our second integrated question with respect to collecting your input. There we go. So some RFI respondents and focus group participants stated that for quality measurement to be useful to patients in decision making, and you can read the rest. So we really are asking you to help us understand what additional types of information or issues could we talk about in subsequent presentations with respect to what do patients need to know. So we'll give you a few minutes to do that. Thank you. Well, thank you very much. We look forward to getting your feedback with respect to what you want us to talk about for getting patients engaged and what they need to know for quality measures. So I'm going to go on for the collaboration education theme. In collaboration, regardless of the type of stakeholder, their perspective, that was a recurrent theme. We need to collaborate more often. One theme that came up was collaboration, not necessarily in a sequence, but it's important that there be collaboration at the same point in time by having all the different stakeholders engaged at one point in time and having open conversation across the continuum of the project. Though it's challenging to do that with a resource limitation, that's a really important opportunity to have and not have things be fragmented as much as possible. As I said, multidisciplinary being brought into play was always emphasized. Another recommendation was that once a meeting is held or there's some types of community or coming together, that folks' ability to follow up with one another and develop a rapport over time is really absolutely critical. We also heard, regardless of perspective, a need for clarity in terminology, not just in identifying particular information, but in priorities and consideration of how a particular suggestion could actually impact the different stakeholders that come to play, which is pretty self-evident, but the recurrence with which stakeholders express concern that they didn't understand what data were available or didn't understand fully how the quality measures could be developed, and an overall more in-depth sharing of what is really expected from each individual stakeholder who contributes to the health IT quality measurement enterprise was a recurring theme. With respect to education, so we had education for two main target audiences that were identified. One was for consumers as in patients, which Christine talked about before. What do patients need to know? What do they want to know? Also, with respect to the discussion of patients, they had a different view of the larger construct of what quality measures are that went beyond with respect to traditional clinical quality measurement. Also, education for purchasers. What type of guidance do they need with respect to what quality information is, how to access it, and how to interpret it. But most of our comments with respect to education had to do with the clinicians themselves or the healthcare providers as an institution, or payers with respect to pay for performance or quality measure developers. And an important partnership that was brought up several times was the importance of engaging of medical and specialty societies and professional organizations to participate in education programs and perhaps offer continuing education credits. the importance of education about quality measures being supported through board certification process. And the critical messages that we heard was there are various venues for education. Know your audience and speak to them, and what do they really know? Need to know with respect to quality measures, have it be as targeted as possible. That if you're going to expect this type of engagement for the education and the use of quality measures, be able to demonstrate that quality measures of interest really improves the quality of care. Give us answers to the so what question. And also, to the extent to which it can be demonstrated that use of quality measurement can have a positive impact on the overall economic standing of an institution, was strongly encouraged. In general, people said that, hey, we haven't seen enough success stories with respect to how quality measurement really can have an impact. Empowering lead folks in an institution, clinicians, or lead administrators within a large institution to be able to demonstrate that the investment of time and other resources by the clinicians and the staff for use of quality measurement, either in inputting the information or use of reporting the information and using that reported information in a quality assurance improvement process, could really have a positive impact. Another concern was, which is alluded to by Anjanette, is how good are the data? Give assurances that the quality measure values and reports are containing accurate and fair assessments of what they're intending to measure. With respect to clinicians in particular, but not limited to clinicians, we heard if quality measures are being generated as a natural byproduct of care, I'm more in favor of that. Don't have it be an additional burden. With respect to need for education tools, multiple people suggested it would be great if the vendors themselves would provide summaries of the functionality that they have with respect to different types of quality measures. This would be extremely useful for people choosing to purchase EHRs or actually implement quality measures themselves. Education tools that are generally tied to actual national programs with respect to quality measures were encouraged. Some particular some particular topics that were of interest to be included in small education programs were terminology, technology as far as the functionality across different health information technologies, and the concept of risk adjustment with respect to if you have quality measures that do reflect the risk adjustment, how is this interpreted, how is it implemented, and what is the impact? Another theme was various quality measures are developed either for state reporting. They're different, you're meeting different needs of different organizations. And I think Anjanette spoke earlier about secondhand use of quality measures. Really, when one seeks to develop a quality measure, keeping in mind how will that information will be used and how will that be integrated into a quality improvement program. And that education is bidirectional. It's not just the person generating the quality measure themselves, but understanding once that quality measure is generated, how is this impacting either the institution or the folks who are monitoring those values. Another suggestion was education with respect to informatics competency. So in the back of the appendix, you can see more about, we had an actual question geared towards gathering information about the use of education and board certification with respect to quality measurement, and you might find that of interest. That's in Appendix A. With respect to pursuing pathways to achieve e-improvements, again, we're thinking about the overall impact and the long-term vision. Where are we going? It's absolutely critical that quality measurement be integral to e-improvement, that it not be just one step along the way, but that it actually goes on a path. And how folks do that is quite varied. Over time, we recognize that there will be incremental advancements made. We're hoping that as you get to know some of the advancements that are being made elsewhere, as identified in our compendium, the 150 different activities that someone thought or more than one person thought would be helpful, that you can look and see who else is making advancements, see if you can piggyback over what they're doing. We also recognized we had a snapshot report. Even though we didn't call the 2013 a snapshot, it really was a quick review based on input that we got from our very generous, and this is a good time. Okay, so when we issue an RFI last summer, folks were saying, hey, you didn't give us enough time. Give us some more days. So we did. We doubled the comment period, and we had very thoughtful responses. Interestingly, of the 15 questions we posed, generally about 2/3 of the respondents would choose to respond to each question. But that was very time-consuming, and we're very appreciative of their efforts. Then we had engaged with about 60 folks through different focus groups, and that took of their time and of their energy to give us their reflections. And often in those focus group discussions, we would have real-time feedback, but we also had folks who were identifying for us subsequently as they would come across other references that we could include in our compendium of example of practical guidance. And we really appreciate that. So that Christine Martin Anderson, who is well known in this field, and Anjanette Fleming and Christina Marsh, her colleagues at Booz Allen, have provided to you a nice high-level report and have provided some unique insight based on the collective responses we received through the RFI. And AHRQ has informed the organization of that material and the presenting it. We really have provided you not a one-stop shopping, because it is not inclusive of all the wonderful activities being pursued by NQF, by CMS, by LNC, but it has provided a large single repository for you to look at. I mean, the VA is involved in this type of activity, the Indian Health Service. I mean, this is quite an integrated, but we're hoping that it'll give you not one-stop shopping, but a nice place to go to find out some of the other activities. As these go on, as these projects occur, the information that we have included will have more of our shelf life will occur. But unfortunately, for some of these challenges, they cannot be met immediately, so some of them will quite be relevant to ongoing conversations in the next 2 to 10 years, actually. But if you look in the body of the report itself, we have the 111 projects suggested, not suggested for AHRQ, but the gaps that are identified as possible infrastructure challenges that could be met. For some of the focus groups, folks offer to us whether or not they felt it would be a near-term or a mid-term activity. We did not engage in that type of prioritization with all the focus groups. So it's not intended to be a recipe of what should happen, but we just share with you what some focus groups thought would be preferable to identify in the near term and midterm, and ask you to consider that. Near term and midterm were just selected as a way, what do we need to do now? What could we do now? As opposed to midterm, there may be sequential activities before we would be prepared enough to go forward. But in conclusion, measure concepts must be prioritized based on potential population-wide effect of achieving improvements in that measure. As we all know, you can't do everything at once. And so as ONC and CMS and IHS and Veterans Affairs and various and so many actual healthcare institutions that are providing care are informing their quality improvement, quality assurance programs, they are going to be driving the new quality metrics that we're going to be using either in a pilot phase or through scaled-up required reporting. And we hope that you have enjoyed the presentation. Really what's important is that if you take the time to go look at the more detailed information that we have presented that was provided by those thoughtful respondents to the RFI and to the focus groups. Let me just say that everything is a collaborative activity, And AHRQ has been very glad to have the support of Booz Allen through this contract to engage with so many different people and perspectives. And we look forward to hearing from you all. If you can just hang on through this feedback forthcoming and in the future. This is an ongoing dialogue that's being conducted both at AHRQ, Booz Allen, CMS, and elsewhere. And collaboration is how we go. And with respect to the perspectives we had talked about earlier, and they really are just examples of, I call them primary color perspectives. So if you we could use that illustration. But in reality, quality measurement's a tie-dyed world. Everything's mixed together and has different patterns. And so I ask you to take a look at the subsequent questions for feedback. We are particularly interested in, of the 5 major topic areas that we have discussed, measurement, development, implementation, and testing, or data elements and data capture tools and process and unstructured data, and the 3rd being data access, sharing, aggregation, and integration, and the 4th being patient engagement, and the 5th collaboration and education. Which of those particular topics in the future you would be interested in us expounding upon how people gave us input that is reflected in the report? And also, thank you for bearing with us as we had the integrated feedback questions early on. Let us know whether you thought that was helpful or not. And we'll take that under advisement. And also, we have a very open-ended question. What other topics or feedback would you like to give us about this project? I thank you all for your time this afternoon. Again, this was the idea of Dr. Jonathan White, and he had the vision, and myself, Rebecca Roper, and Christine Martin Anderson, and Anjanette Fleming, and Christina Marsh, and the extended Booz Allen team, we had the mission that was realized through a cooperative activities across the federal government as folks gave us advice and counsel, as well as the public and other members of the public sector and the private sector as well. And with that, I will turn it over to say farewell from Christine.
Thank you all very much for your time. In looking at the registrations, I know many of you are those that are very highly dedicated to quality and have been in this field for quite some time. We know you have many points that you can offer us to make the advancement even better. So we thank you for sharing your comments now or through the poll or in the future. So thank you. And thank you to AHRQ for giving us the opportunity.
Okay. Have a good weekend and a good Friday the 13th.